Hello everyone, we'll discuss here pediatric electrocardiogram. Check all the updated information in the third edition 2024-2025.
This is a 12 leads ECG 10 seconds recording. We have large squares and small squares. Each small square equal 1 millimeter by 1 millimeter in size. Each large square has 5 small squares by 5 small squares, or 5 millimeters by 5 millimeters. Very important to look at the calibration. Standard calibration is 2 large squares for the amplitude. 2 large squares for the amplitude, or 10 millimeters. The standard speed is 25 millimeters per second. In this case, each small square equal 0.04 seconds or 40 milliseconds, and each large square equal 0.2 seconds or 200 milliseconds. In this case, 5 large squares will be equal 1 second. If 1 second equal 5 large squares, this means 60 seconds equal 300 large squares, or 1 minute equal 300 large squares. If we take one cardiac cycle from here and we look at it, we have wave, we have segment, we have complex and intervals. So wave means deflection. If the deflection is above the baseline is positive, if it's below the baseline is negative. Then we have segment, which is a portion of the baseline, and the interval means a wave plus segment, and complex means multiple waves without segments. P wave represents atrial depolarization. PR interval represents atrioventricular conduction, and the QRS complex represents ventricular depolarization. ST segment and T wave represent ventricular repolarization. The QT interval from the beginning of the Q to the end of the T means the duration of ventricular depolarization and ventricular repolarization. When we look at the ECG, we have 12 leads ECG, and we look at the rhythm leads in the bottom. The rhythm leads in the bottom to look at the rhythm and rate. Then you have here the 12 leads. You have lead 1, 2, 3, AVR, AVL, AVF, V1 to V6. Lead 1, AVL, and V5 and 6, they are well known as lateral leads, and they look at the electrical activity of the lateral wall of the left ventricle. Then you have 2, 3, and EVF, well known as inferior leads. Inferior leads, they look at the electrical activity of the inferior surface of the heart. Then you have septal leads V1 and V2, and V3 and V4, well known as anterior leads, and they look at the electrical activity of the anterior wall of the right and left ventricle. V1 and V2, they are a great window for the right ventricles. V5 and V6, they are great windows for the left ventricle. Then when you look at the ECG, you start to analyze the waves, and we need to be familiar with the variation of waves in different leads, and also variation of waves according to the age. So if we start here, PQRST, 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 you see here the P wave is positive in lead 1 but is negative in AVR. This is normal. So if you look at here, also the T wave is positive in lead 1 but is negative in AVR and V1. This is also normal. But T wave can be positive normally in newborn less than 7 days or less than 1 week of age. Afterward, if it stays positive, this is suggestive of right ventricular enlargement, just suggestive, but can be normal in older children, like older than 6 to 7 years of age. Then we need to look at the QRS ratio and variation according to the age. This ECG is for 8 years old. If this is a newborn, you will see the R wave here in V1 is larger than that, and the S is smaller than that. As the infant and children, they grow, the R wave keep declining, keep getting smaller in V1, and the S keep getting deeper, and the opposite occurs in V6. So this is also variation. Very important also to know that the QRS ratio in V1 is different than the QRS ratio in V2 and V3. So this is very important to consider before start reading an ECG. Very important to have a systematic approach when you are reading electrocardiogram in order not to miss any important information. Step 1, you look at the rhythm, rate, and the axis. Step 2, to look at the P wave, PR interval. Step 3, QRS complex. Then step 4, you look at the QT interval, ST segment, and finally T wave. So step number 1 is to look at the rhythm. If it's regular or irregular, make sure that each QRS is preceded by P wave. P wave can be normally negative in AVR. The rate, if the rhythm is regular, you divide 300 by the number of large boxes between the R's. If the rhythm is regular, you can count the heart rate by dividing 300 by the number of large squares between the R's. So we have 1, 2, 3, 4. So 300 divided by 4 equal 75. So where the 300 came from, again 1 minute equal 300 large squares, because each large square equal 0.2 seconds. So if you have one large square between the R's, just one, the heart rate will be 300. If it's 2, will be 150. If it's 3, will be 100. If it's 4, will be 75. If it's 5, will be 60. If it's 6, will be 50. This is in case if the rhythm is regular. Heart rate per minute in irregular rhythm. If you are using 6-second strip, like this one is a 6-second strip, 5 large squares equal 1 second. So we have here 6 seconds. So you need to count the R's in a 6-second strip, and then you multiply by 10. The idea here, you need the heart rate per minute. So you need to make it 60 seconds. So 6 seconds, you time by 10 to make it 6 seconds, which is 1 minute. Here 11 R's time 10 equal 110. So the heart rate in this patient 110. If you are using 10-second strips, you multiply by 6, which is the most commonly we use now, to make it 60 seconds, which is 1 minute. So it's very easy just to count the R's and multiply by 10. If you are using 6-second strip, if you are using the 10-second strips, you multiply by 6, and this will give you the heart rate in irregular rhythm. After rhythm and rate, we need to know the axis. To know the axis, you need to look at the QRS in lead 1 and AVF. If both are positive, this is normal axis. If the QRS is positive in lead 1 and negative in AVF, this is left axis deviation. If the QRS is negative in lead 1 and positive in AVF, this is right axis deviation. If both of them are negative, this is extreme axis deviation. Again, to make it easy to remember the axis, if the QRS is positive in lead 1 and positive in AVF, this is normal axis. This is normal, will be looking this direction. If the QRS is positive in lead 1 and negative in AVF, this is left axis deviation. If the QRS is negative in lead 1 and positive in AVF, this is right axis deviation. If both of them are negative, this is extreme axis. Normally newborn and young children, they will have normally right axis deviation, will be looking this direction somewhere here. And as they grow, the force will be moving towards the left ventricle, and they will start to have normal axis. And the QRS will be positive in lead 1 and positive in AVF. But normally newborn infants and young children, normally they have right axis deviation, and as they grow, it will move towards the normal axis. After analyzing rhythm, rate, and axis, we look at the P wave. If the P wave is tall and peaked, more than 3 millimeters or more than 3 tiny squares, this is an indication of right atrial enlargement. If the P wave in lead 2 is broad and M-shaped or broad, more than 3 tiny squares, more than 120 milliseconds, this is an indication of left atrial enlargement. Also, you can look at the P wave in V1. If it's deeply negative in V1, this is also another indication of left atrial enlargement. So easy to remember, if the P wave is peaked taller than 3 tiny squares in lead 2, this is the right atrial enlargement. If it's broad, wider than 120 milliseconds or more than 3 tiny squares, this is left atrial enlargement. So in this ECG, the calibration is a standard calibration. It's 2 large squares, 10 millimeters, as you see here, and the speed is 25 millimeters per second, which is a standard speed. If we look at the rhythm is regular. So there is a 3 large squares between the R's, so 300 divided by 3. So the heart rate here approximately is 100 beats per minute. Then we look at the axis, the QRS is positive in AVF and is negative in lead 1. This is right axis deviation. Then if we look at the P wave before in lead 2 before the QRS, it is tall and peaked, is obviously more than 3 tiny squares. So this is suggestive of right atrial enlargement. This is another example of atrial enlargement. If you look at here, the P wave is taller than 3 tiny square and also wide. And in V1 is very deep negative or deeply inverted P wave in V1. This indicates left atrial enlargement. So tall and deep also in V1. This is indicate right and left atrial enlargement and possible left ventricular hypertrophy. In this case, you will see here the S is very deep in V1, the R is almost, you cannot see it, and the R here is large in V6, so this possible left ventricular hypertrophy. So again, P wave is negative in V1, this is left atrial enlargement. Here is tall in lead 2 and also wide at the same time, so this is right and left atrial enlargement. After the rhythm rate axis P wave, next step is to measure the PR interval. PR interval usually less than 200 milliseconds in older children and less than 130 milliseconds in newborns. Know that PR interval varies according to the age and heart rate. So we need to check if the PR interval is prolonged, normal, or short duration. If you find the PR interval is prolonged in all leads, this is first degree heart block. PR interval more than 95th percentile for age or heart rate, this is first degree heart block. Typically if it's more than 200 milliseconds or 1 large square. This is a 14 years old asymptomatic with cardiac murmur. If we look at the rhythm strip here, the rhythm is regular. The heart rate here divide 300 by 3 equal 100 beats per minute. If you look at the PR interval here is prolonged, is more than 1 large square, is 230 milliseconds, and all P waves successfully conduct to the ventricles. There is no missing QRS. So this is a first degree heart block. Second degree heart block is Mobitz 1 or Mobitz 2. Mobitz 1 or Winkeback, it is a progressive prolongation of PR interval until there is a loss of AV conduction or a loss of the QRS. So progressive prolongation of PR interval until a loss of the AV conduction. If you look in this ECG, you will see the PR interval keep getting longer and longer. And then followed by a loss of AV conduction or loss of 1 QRS. We're supposed to have 1 QRS here, but it's not there. So this is an example of a second degree heart block Mobitz 1. If the PR interval is normal but periodically there is a drop in QRS, this will be known as second degree heart block Mobitz 2. This is a normal PR interval, is not prolonged, but there is a periodic drop in the QRS. One drop here and there is another drop here. This is a second degree heart block Mobitz 2. Third degree heart block or complete heart block, no atrial depolarization is conducted through the AV node. So you will see the atrial waves and the QRS complexes are independent. So the P and the QRS have independent but regular or fixed rate. This is an ECG for 2 months old after heart surgery. If you look at the rhythm here, the rhythm looks regular, and the heart rate for this 2 months old, we have 4 large squares between the R's, so 75 beats per minute, which is considered bradycardia for 2 months old. If you look at the P wave here, you will see the P wave in different locations. You have one here, another P wave here, another P wave here on the top or at the end of the T, another P wave here, another P wave in this location. There is no P wave here. So the QRS is independent of the P waves. So this is complete heart block bradycardia with AV dissociation. Management of heart block, observation for first degree heart block and second degree Mobitz 1. Management of second degree Mobitz 2 and complete heart block in cases of emergency bradycardia, temporary transcutaneous or transvenous pacing is the treatment of choice. Atropine may be used in case of emergency in the first and second degree heart block. Atropine may worsen complete heart block, so choosing atropine for complete heart block is always wrong. So this is a high yield. Permanent pacemaker may be necessary. After checking the rhythm rate axis P wave and PR interval, now we need to look at the QRS complex. QRS complex normally less than 120 milliseconds. You need to make sure the QRS complex is not a wide complex, is normal duration, and is not a narrow complex. Very important to look at the QRS amplitude and RS ratio. Very important if you are looking at ECG for a very young child or younger child, you need to consider the variation according to the age. Upper and lower normal limits for age. Large R in V1, and deep S in V6, this is right ventricular enlargement. Because this is pediatrics, if the R in V1 more than upper limit of normal for age, and if the S in V6 more than upper limit of normal for age, this is right ventricular enlargement. So you need to consider the variation according to the age. For example, in V1, in newborn, the R wave is relatively large because of the high force of the right ventricle, and the S wave will be smaller. And as the infant and the children they grow, the R wave in V1 will keep getting smaller and the S will become deeper as the children they grow, and the opposite occur in V6. T wave can be suggestive of right ventricular enlargement. Very important to know that positive T wave in V1 in the first week of life is normal. Positive T wave in V1 after the first week of life is suggestive of right ventricular hypertrophy or enlargement. Positive or upright T wave in V1 is not abnormal in children more than 6 years of age. This is a regular rhythm. If we look at the heart rate, we have 3.1 large squares, so 300 divided by 3.1. The heart rate here is 96 beats per minute approximately. Then if you look at the axis here, the QRS complex is negative in lead 1 and positive in AVF. This is right axis deviation. Then if you look at the R to S ratio in V1, the R is large in V1 and the S is deep in V6. This is right ventricular enlargement. If you have a deep S in V1 and large R in V6, this is left ventricular enlargement. Again, to be more specific, because this varies according to the age. If the S in V1 is more than upper limit of normal for age, and if the R in V6 more than upper limit of normal for age, this is left ventricular enlargement. This is an example of left ventricular enlargement. If you look at here, the S wave is very deep in V1 and the R wave is very large in V6. This is left ventricular enlargement. So deep S in V1, larger than normal R wave in V6. This is left ventricular enlargement. Right bundle branch block is a high yield in pediatrics. It is more common in children, particularly after open heart surgery. Check V1. If the QRS in V1 is wide, more than 120 milliseconds or more than 3 tiny squares, and there is R wave. So very important to have wide QRS complex with R wave. This is right bundle branch block. This is an ECG for 16 years old with tetralogy fallow repaired in infancy. If you look at the QRS complex in V1, it is a wide complex. So there is a wide QRS complex in V1 and there is RSR pattern. So there is R wave and wide QRS complex in V1. This is a right bundle branch block. And if you look also at the S wave in V6, it is wide. So again, right bundle branch block is wide QRS complex in V1 and there is RSR pattern here. This is a right bundle branch block. Premature atrial contractions, very common in pediatrics, very common in neonates, usually asymptomatic and requires only reassurance. No consultation, no treatment is necessary. Causes idiopathic caffeinated drinks, electrolyte imbalances, and medications. This is an example of a premature atrial contraction, which is unexpected early heartbeat. So if you look at here, PQRST, then PQRS, then suddenly you will have a premature heartbeat. Compare here, there is almost 4 large squares, and here is only 2 large squares. So this is a premature heartbeat. Is it atrial or ventricular? If it is preceded by P wave and followed by normal QRS complex, it is premature atrial contraction. It is very benign and requires reassurance. So if it's ventricular, you will see no P wave and is not, the QRS complex is not normal, is wide and bizarre. So, but in this case, in premature atrial contraction is preceded by P wave and followed by normal QRS complex. The P wave may look different than other P waves. Clinical presentation of premature atrial contractions, palpitations, skipping or missing heartbeat or pause. In newborn, the nurse may call you because of irregular heartbeat. The management in this case, no additional evaluation is necessary, no consultation. Avoid inciting agents, for example caffeine. Refer if it is associated with dizziness, syncope, chest pain, or shortness of breath. Just reassurance is the answer. Premature ventricular contraction is because of ectopic beats originating from the ventricle, may occur as many as 25% of healthy children, can be a presenting sign of myocarditis or cardiomyopathy, occurs more frequently in patients with structural heart disease. Clinical presentation of premature ventricular contraction usually asymptomatic, but may present with chest fullness, dizziness, feeling skipping or missing beats, then resumes with a strong beat. If you look at this ECG, you have a PQRST, then suddenly you have a premature wave. Is not preceded by P wave and followed by wide bizarre QRS complex. So this is a premature ventricular contraction and is repeated again, very similar, and repeated again here, another premature ventricular wave, very similar. So this is a uniform premature ventricular contraction. It is very benign, especially if there is no symptoms, there is no family history of sudden death. Also, if it's suppressed with exercise, it is very benign and requires reassurance. Multiform, you will see here positive deflection, negative deflection, they look different. So if they look different, this is multiform premature ventricular contraction. If it's exaggerated and become worse with exercise, this is abnormal and requires referral. Management of premature ventricular contraction, no treatment is necessary if single, uniform in appearance, suppressed or not aggravated by exercise. If it is aggravated by exercise, it is not normal and requires evaluation. No evidence of underlying structural heart disease, or there is no family history of sudden death. If there is a family history of sudden death, if there is underlying structural heart disease, requires referral and evaluation by a pediatric cardiologist. After rhythm, rate, axis, P wave, PR interval, QRS complex, now we need to measure the QT interval. Two intervals very important to measure in the ECG: PR interval and the QT interval. QT interval varies according to the age and heart rate. So very important to consider the age, very important to correct for heart rate. So the corrected QT interval should not exceed 0.44 seconds except in infants. QT interval corrected up to 0.49 seconds may be normal in infants less than 6 months. Corrected QT interval more than 0.45 seconds may be abnormal. The formula we use for the correction of QT divided by the root square of R to R. Very important in this case, we use seconds, not milliseconds. Seconds, not milliseconds. Possible causes of prolonged QT interval: medications, tricyclic antidepressant overdose, for example amitriptyline or imipramine, ampicillin, erythromycin, trimethoprim, sulfamethoxazole, or Bactrim. Electrolyte abnormalities, for example hypocalcemia, hypomagnesemia, or hypokalemia. Genetics, like for example mutations of genes encoding for cardiac ion channel proteins, for example potassium or sodium. Two syndromes very common, high yield in pediatrics, is Romano-Ward syndrome, Jervell-Lange-Nielsen syndrome. This is commonly associated with deafness. Romano-Ward syndrome is not associated with deafness. Clinical presentation of long QT syndrome. Very important if you have a long QT on the ECG or a history of syncope. We have to ask about family history of unexplained sudden death. Congenital deafness in the family. This suggests or may suggest this syndrome, Jervell-Lange-Nielsen syndrome. Also, the long QT syndrome may present with fainting spells while swimming, startling, or exercising. Syncope, seizures, palpitations, or cardiac arrest. As many as 10% have episodes of sudden cardiac arrest. This is an ECG for 15 years old boy, loses consciousness while playing football. He regains consciousness quickly. The calibration of this ECG is a standard calibration. For the amplitude is 2 large squares, and for the speed is 25 millimeters per second. First thing, we look at the rhythm. The rhythm is regular rhythm. and the heart rate is 5 large squares between the R's, so 300 divided by 5 equals 60. So there is the heart rate here 60 beats per minute approximately. Then if we look at the also there is a P wave before each QRS, it is a sinus rhythm. Then if we want to calculate the QT interval, the best place to look at is lead 2. So you drop one line from the beginning of the Q and another line at the end of the T. Then you extend another line at the downward part of the T wave to the isoelectric line, and this will include the U wave if it's present, to get the exact ending of the T wave. Then you measure the QT time. The QT time here is 2 large squares and another 3 tiny squares. So 0.2 plus 0.2, 0.4, and the 3 tiny squares, 0.04 times 3 equal 0.12. So the adding this to this is 0.52 seconds. Then the R to R, we have 5 large squares between the R's, so 5 times 0.2 equal 1 second. So the root square of 1 is 1. So the formula here for the corrected QT interval, it is QT divided by the root square of R to R. So 0.52 divided by 1 equal 0.52. This is a long QT syndrome. That's why this adolescent is losing consciousness because of the long QT syndrome, and this can be precipitated by fear, startling, by swimming, exercise, because of increase of adrenaline, and this will prolong the QT and can precipitate ventricular tachyarrhythmia and possible sudden death. Early detection, early referral, and the treatment of cases of long QT syndrome is critical to prevent fetal ventricular tachyarrhythmia, syncope, and sudden death. The treatment is beta blockers are very effective in preventing cardiac events in 70% of the patients. Implantable cardioverter defibrillator or ICD is highly effective in preventing sudden cardiac death in high-risk patients. Very important to advise, very important to give the patient a list of the medication that cause a prolonged QT interval, and the patient has to avoid these type of medications. Atrial flutter. The atrial rates of 300 to 400 beats per minute with variable conduction, so that the ventricular rate is slower than the atrial rate. So the ventricular rate is slower than the atrial rate. So the way to count the atrial rate by counting the P waves, and the way to count the ventricular rate by counting the QRS complexes. Then you compare. Clinical presentation: infants may present with congestive heart failure. Older children may have palpitations, dizziness, syncopes, chest pain, and shortness of breath. Prolonged atrial fibrillation or flutter more than 24 hours. This can result in a clot in the left atrium. Diagnosis of atrial flutter, very important to be able to count the P waves and also to count the ventricular rate. So the atrial flutter most commonly conducts to the ventricles in 2-to-1 fashion. For example, if the atrial rate is 300, you expect the ventricular rate to be 150. If it's 400, to be 200. Classic inverted sawtooth appearance or deflections that are best seen in lead 2-3 and AVF. This is an ECG for a newborn with irregular heart rate. First thing, we look at the rhythm. The rhythm here looks irregular. So in order to count the heart rate in an irregular rhythm, we need to count the R's, then multiply by 6. Why 6? Because here we have 10 seconds recording ECG. So here we have 17 R's times 6 equal 102. So the approximate ventricular rate is 100. If we look at here, we will see multiple P waves. We have here between the QRS complexes, we have 3 waves. So the atrial rate is 300. So we have here 300 to 100 means the conduction is 3-to-1. And also you can see here the classic sawtooth appearance of the atrial flutter. So this is a case of atrial flutter with 3-to-1 conduction. This is an ECG for 15 years old with atrial septal defect. If we look at here at the rhythm, we'll find the rhythm is a irregular rhythm. Then if we try to identify the P waves, it's very hard to identify nuclear P waves before the QRS complexes. This is a case of atrial fibrillation, irregular with nuclear P wave. Management of atrial flutter requires urgent cardiac evaluation and treatment. Synchronized electrical cardioversion performed if no thrombus, however, can be used in highly unstable patient before rolling out a thrombus. Chronic atrial flutters more than 2 weeks, or if thrombi identified, in this case you give medication with anticoagulant like diltiazem or beta blocker for 2 to 4 weeks, then you do the cardioversion afterward. Radiofrequency catheter ablation may cure most types of atrial flutter. Supraventricular tachycardia, very common in pediatrics. SVT is defined as a rapid tachycardia originating above the bundle of Hess. Pathogenesis: reentrant tachycardia using an accessory pathway. Reentrant atrioventricular nodal tachycardia, this is common in adolescents. Ectopic atrial focus. Supraventricular tachycardia clinical presentation varies by age. In infants, the heart rate will be elevated, persistently elevated, between 220 and 270 beats per minute. When the nurse is trying to get intravenous line and the infant is crying and the heart rate is 180 and goes back to normal after, this is not supraventricular tachycardia. The infants may present with poor feeding, pallor, irritability, lethargy if prolonged, congestive heart failure. In school-aged children may present with palpitation, heart pounding, chest pain, or fullness, shortness of breath. The heart rate will be between 180 and 240 beats per minute and persistent. Diagnostic criteria for supraventricular tachycardia: narrow complex. This is very important. So not wide complex, is narrow complex tachycardia with non-variable rapid heart rate. P waves are often difficult to see but may be seen as sharp deflections within the T waves. This is an ECG for 12 years old with palpitation. Step number 1 is to look at the rhythm. The rhythm here is regular. Then the next step is to calculate the heart rate. You have here 1.6 large squares, so divide 300 by 1.6 equal 187. Another method, this is a 10 seconds ECG recording. We have here 30 hours, so times 6 equal 180. So 180 is more than the upper limit of sinus tachycardia for this age group. So this is abnormal. This is a tachycardia. Also, there is no variation. There is non-variable rhythm. So there is no variation in the heart rate. Also, if you look here, there is no P wave and the QRS complex is narrow. So this is a case of supraventricular tachycardia. Supraventricular tachycardia has to be managed as soon as possible because prolonged supraventricular tachycardia, for example, in infants, can cause congestive heart failure. If the patient is stable, vagal maneuvers, for example, placing eyes back to the face for 10 to 20 seconds. The drug of choice is IV adenosine. Avoid verapamil in infants less than 1 year because this can cause hypotension and shock. Avoid digoxin in Wolff-Parkinson-White syndrome. Beta blockers is a medication can be used if you treat medically, and most of the children, they respond to medical treatment. If the patient is unstable, cardioversion is the right answer. Pediatric cardiology referral for management. These patients, especially if they are not responding to beta blockers, if they are old children, they respond very well to electrophysiological studies with ablation procedure. This is the definitive treatment of choice, especially in older children and if it's not responding to medical treatment. Wolff-Parkinson-White syndrome is a condition in which an aberrant accessory pathway causes pre-excitation of the ventricles. Associated conditions: cardiomyopathy, Ebstein's anomaly, corrected transposition of great arteries. Presentation is an incidental finding on an ECG or a tachyarrhythmia. Diagnostic criteria of Wolff-Parkinson-White syndrome: short PR interval, slurring and slow rise of the initial upstroke of the QRS complex, which is well known as delta wave. Wide QRS complex, which is more than 3 tiny squares, or 0.12 second or 120 milliseconds. This is an ECG of 8 years old boy with palpitation. First step is to look at the rhythm. The rhythm here is regular. Then the next step is rate. 2.5 large squares, so 300 divided by 2.5 equal 120. Another method, we have 20 hours here, so 20 times 6 equal 120. Then the next step is to look at the axis. We have here the AVF is negative and is positive in lead 1. This is left axis deviation. Then after that we look at the P wave and the PR interval. The P wave here looks normal, but the PR interval is very short. If we magnify it here, the PR interval is very short. And if we look at the QRS complex is a wide complex, then also we have here a slurring of the initial upstroke of the R wave. This is delta wave. So this patient meets the criteria of the diagnosis of Wolff-Parkinson-White syndrome, tachycardia with pre-excitation or short PR interval with wide complex and slurring of the initial upstroke of the R wave or delta wave. Tricyclic antidepressant toxicity, the ECG finding is very important. The most common is sinus tachycardia, prolongation of PR interval QRS and corrected QT interval. Non-specific ST segment and T wave changes. QRS interval greater than 100 milliseconds is the basis for the treatment with bicarb for alkalinization. This is a wide QRS complex in a patient overdosed with a tricyclic antidepressant. Ventricular tachycardia, definition of ventricular tachycardia in children is defined as tachycardia of at least 3 successive ventricular beats. A ventricular, when we say ventricular, means that the QRS will be wide and bizarre. Wide complex, not narrow complex. If it's narrow complex, it will be supraventricular, not ventricular. Ventricular when the complex is wide, and we'll see it in the example. Causative factors include drugs, caffeine, decongestant, so be careful about prescribing decongestant, especially to very young children. Be careful with the dose. Electrolyte imbalance, underlying cardiac disease, prior cardiac surgery, and cardiomyopathy. Clinical presentation of ventricular tachycardia. Many patients are asymptomatic. They may present with pallor, fatigue, chest palpitation, and syncope. ECG criteria of ventricular tachycardia: bizarre wide QRS complex tachycardia more than 120 milliseconds, and which is usually regular rhythm. P wave may or may not be recognizable depending on the ventricular rate, and the T wave usually in the opposite direction of the QRS. The QRS complexes may vary in appearance if the ectopic input is multifocal. This is a rhythm strip for 6 years old who presented with difficulty breathing. If we look at the rhythm here, the rhythm looks regular. Then the rate here, you have 1.8 large square. So if you divide 300 by 1.8 equal 160. So the approximate heart rate here is 160 beats per minute, which is more than the upper limit of sinus tachycardia for 6 years of age. 6 years of age, the upper limit is about 133 beats per minute, but here is 160. So this is a tachycardia. Then you try to identify if there is any P wave. There is no P wave, you are able to identify. Then we analyze the QRS complex is wide and bizarre. When the QRS complex is wide and bizarre, this is ventricular tachycardia. Management of ventricular tachycardia. This is a pediatric cardiac emergency. Any patient identified as having ventricular tachycardia should be assessed immediately for hemodynamic instability. Once clinically stable, this patient they require complete cardiac evaluation, including radiography, echocardiography, exercise stress testing, and 24 hours Holter monitoring. Ventricular fibrillation is a rare pediatric life-threatening cardiac emergency. In this case, the heart tremors rather than contracts, so there is no actual systole and diastole. The heart is not pumping blood, therefore you do not feel pulse, so similar to asystole. ECG finding in cases of ventricular fibrillation: bizarre random waveform without identifiable P waves or QRS complexes, and a roaming baseline. Management: any patient with suspected VF requires advanced cardiac life support intervention because the circulation ceased or stopped within seconds of onset. Asynchronous cardioversion required in this case. This is a case of ventricular fibrillation. As you see here, the waves are bizarre, very hard to identify P or QRS. This is ventricular fibrillation. This is cardiac emergency. ST segment evaluation. Cardiac ischemia is rare in children, but this can be seen in cases in anomalous coronary artery, premature coronary artery disease, like in cases of homozygous familial hypercholesterolemia, and this can show elevation or depression in the ST segment. Acute pericarditis, you will see ST segment elevation in all leads. This is diagnostic. This is an ECG for 14 years old with a chest pain. If you look at the ST segment here, if you compare it to the TP segment from the end of the T to the beginning of the P, it is elevated in all leads as you see here. Elevation of ST segment in all leads, this is perimyocarditis. After rhythm, rate axis, P wave, PR interval, QRS complex, QT interval, and ST segment, the next step is to check the T wave. T wave is normally negative in EVR and V1. So normally negative in EVR and V1. Positive T wave in V1 after the first week of life is suggestive of right ventricular hypertrophy. However, if it's positive after 6 to 7 years of age, this can be normal. Differential diagnosis of peaked pointed T waves, hyperkalemia, left ventricular enlargement. Differential diagnosis of flattened T waves, hypokalemia, hypothyroidism. Remember, hyperkalemia causes peaked pointed T wave. This is high yield. This is a case of acute renal failure with hyperkalemia with serum potassium 6.5 mg per deciliter. Very important to know that the changes in the T wave and the ECG with hyperkalemia depending on the level of the potassium. Like in this case, 6.5, as you see here in the precordial leads, the T wave is peaked and tall. But if the serum potassium goes higher than that, for example, this can cause prolonged PR interval, decreased or disappearing P wave, and wide QRS complex. Very important to keep in mind. Sinus arrhythmia is a normal variation in healthy children, a normal variation in heart rhythm caused by breathing. When we breathe in, this will cause or create negative pressure in the chest, increase venous return. This will increase the heart rate slightly, and during expiration the opposite will occur. This is normal. This is requires just reassurance. Here, this is a case of sinus arrhythmia, PQRST, and here slower then faster, slower than faster. This is during expiration, during inspiration, expiration, inspiration. This is normal, requires reassurance. This is the end of my presentation. Thank you for listening.
Having trouble or trying to pass the pediatric board exam? We have the definitive solution for you, presenting the Last Minute Review Series, a powerful tool for achieving success in pediatric board exams, crafted by Dr. Osama Naga, a board-certified pediatrician by American Board of Pediatrics and the editor of the Pediatric Board Study Guide, a last-minute review. Dr. Naga breaks down the most critical subjects in this series. The Pediatric Last Minute Review webpage offers a thorough and rigorous set of pediatric board review sessions that are in line with the study guide. The lectures will cover the most important topics for each condition that a pediatrician must know for pediatric board exams, as well as real-life clinical encounters. The inclusion of a clinical case scenario, accompanied by multiple choice questions, followed by the most probable answer and a comprehensive description of the issue, will ensure test readiness for each student. You will be able to download the lecture's PDF files to make your studies easier, to take notes and be accessible on the go and offline. Based on the membership plan you choose, you will have unlimited access to the lectures for either 1 month, 3 months, 6 months, or 1 year. By viewing these videos, you will increase your chances of passing the board exam and gain substantial advantages from the acquired knowledge. Additionally, by studying the material and completing the AAP prep questions from the previous 3 years, you will greatly increase your likelihood of passing the board and will acquire a wealth of knowledge. Click on the link provided below to visit lastminutepediatric.com and subscribe immediately. Be sure to take advantage of our free video samples on our YouTube channel, Pediatric Board Last Minute Review. Good luck with your exams.
This video is only for educational purpose and not intended to direct the care of any specific patient. Please consult your physician or the physician of your child for the correct diagnosis and the proper treatment. None of my videos can be superior or an alternative for the opinion of an experienced and licensed healthcare professional. Thank you again.